Dr. Prashant, you can start your session.
Thank you. Good afternoon, doctors. Greetings from Hetero Healthcare. Welcome to this webinar on the rational approach to viral respiratory tract infections. This webinar is brought to you by Hetero Healthcare. Hetero Healthcare being an innovative pharmaceutical company. For Hetero Healthcare, the journey began in 1993. We have 30 years of excellence and 36 state-of-art manufacturing facilities, 300 plus products in portfolio and presence in 126 plus countries. Hetero Healthcare has 21,000 employees globally and is the largest closely held pharmaceutical company in India. Hetero Healthcare is among the largest manufacturers of ARV, APIs, and FDFs in the world and has Asia's largest API manufacturing facility at SEZ Complex, Visakhapatnam, Andhra Pradesh. Hetero Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties. Hetero Healthcare pioneers in quality and innovation and has the distinction of bringing 4 biosimilar products to market within 5 years of initiation. They are darbepoetin alpha, rituximab, bevacizumab, and adalimumab. During COVID-19 pandemic era, Hetero Healthcare, the pioneers in antivirals, offered oseltamivir, favipiravir, and remdesivir to the patients, because of which in August 2020, Hetero Healthcare received an award of Pharma Excellence for COVID drugs. Today's webinar, Rational Approach to Viral Respiratory Tract Infections, we have got Dr. Ketan Shah, sir, as our moderator. Welcome, Dr. Ketan Shah. Dr. Ketan Shah, sir, is MD, DCH, sir, is President, Surat Pediatric Association 2003, National Trainer, ATM, PSPP, ASK, IAP, CPIDC, How Do I Investigate, Rational Antibiotic Practice, National TB Module, Rapid Module, National Secretary, Pediatric Rheumatology Chapter 2005 and 6, Organizing Chairperson, National Rheumatology Meet 2006, EC Member, Gujarat Pediatric Association 2014-2019, EC Member, ID Chapter 2013. With this brief introduction, I hand over the session to Dr. Ketan shah. Over to you, sir.
Thank you, Dr. Prashant. Thanks to Hetero team for giving me this opportunity. I'll just share my screen.
You are sharing your slides, or I should continue, sir?
No, I have prepared. So I'm sharing slides.
Okay, then I will stop.
Is it visible to you?
Yes, sir. Yes, sir. Very much.
Okay, fine. Okay. Good afternoon, everybody. All doctors viewing this seminar, my regards to you all from Surat. I came to know that you all are from Gujarat, so in between we can have a talk in Gujarati also. The whole concept is how to approach rationally to viral respiratory tract infections. First and foremost, what are the common signs, symptoms of viral respiratory pathology? When do we suspect acute respiratory tract infection as a probable viral etiology? Any child coming to you with primarily a watery running nose, coughing, congested eyes, and has a diarrhea and a fever and family history of ARI or a respiratory infection, probably these has a viral etiology. Either it is a 1-month-old child or maybe 6, 7, 8, 9 years old child also. When you get two systems involved, like in this case, there is a diarrhea and a respiratory involvement with congested eyes. So most likely, this is a viral etiology. Like 4 years male Piyush who had came with running nose, watery discharge for 2 to 3 days, and mother says that child had a cold for 2 days. Even the family member has a cough, cold, and low-grade fever. So primarily, this is a viral respiratory tract infection in 4 years old child. What should be the treatment? Normally, any viral respiratory, they just need a symptomatic treatment. There are thousands of medicine available for cough formulation. But as we all know that government has banned so many cough syrups and ingredients also. So we can use antihistaminic, maybe in the form of levocetirizine or cetirizine in a younger child. Sometimes we may use a topical drops like normal saline, If it is a very bad coughing, then sometimes a levolin, a salbutamol nebulizer can be used occasionally. There is an undefined role of zinc and vitamin C. No doubt they are not going to harm them, but as a placebo also zinc can be given. Round the clock paracetamol is the first choice of treatment. Occasionally we can give ibuprofen if it is a severe myalgia. Rest of the NSAIDs like diclofenac, mefenamic acid, nimesulide, combination of paracetamol with some other drug should not be used. So rationally, paracetamol is the only drug. Occasionally, antihistaminic containing cough syrup would help them. And maybe just a simple home remedy like honey, warm water gargles. If it is an older child of 8-9 years, just a simple steam with some addition of some camphor oil, etc., that may help you out, but not the standard recommendation. We just go to the one more patient, Noor, 4 months female, on direct breastfeeding, family history of respiratory tract infection, child has a low-grade fever, cough, cold, respiratory distress is there, there is a coughing, but child is feeding well, is an active child. We call these as an happy wheezer child. Here, usually the etiology is a viral, and our clinical diagnosis is bronchiolitis. Bronchiolitis is commonly caused by RSV virus, and it is a seasonal epidemic. Last year, we had a very bad bronchiolitis cases. The modality of treatment would be a supportive, some bronchodilator, occasionally the nebulization. In few severe bronchiolitis, steroids would help you out. Antibiotic has no role to go, but occasionally few patients may develop secondary pneumonia. They may need an antibiotic, and few children who are happy wheezer goes into the respiratory distress. They may need a supportive treatment, and bronchiolitis takes a long time, maybe 10 to 15 days also. So in a treatment of bronchiolitis, occasionally we are using ribavirin. Ribavirin is an antiviral drug. The indication of ribavirin would be a severe bronchiolitis on onset, preterm babies, growing with underweight, has a comorbidity, then probably the early starting of antiviral drug ribavirin in the dose of around 10 to 15 milligram per kg per day. Syrup formulation is not available, only capsule is available that can be broken down, and according to that, some preparation at home can be made. This is not a standard recommendation, but high-risk baby would be benefited from ribavirin. Nowadays, we have a RSV monoclonal antibodies, which are available in Western world, has been recently available in Indian market as a preventive therapy, not as a therapeutic. But these monoclonal antibodies, like a vaccine, is given once a year for extreme preterm babies or a high-risk baby having a comorbid disease. Then probably this can be given as a vaccine to the early infant child. So in just nutshell, the analysis would be fever, cough, running nose. Probably it looks like a viral fever. Any child having a cough, low fever, no runny nose, maybe an allergy or atopic condition. A child having a cough, cold, fever, very sick looking, there is a chances that this is bacterial disease. Any child having a chronic cough, chronic is defined as more than 6 weeks, low-grade fever, no running nose, probably this is an ongoing lung parenchymal disease. And this children needs an evaluation. If there is an associated weight loss, family history of tuberculosis, most likely this fit into the ongoing lung parenchymal disease in the form of COX. Any child having a recurrent cough, mother would tell કે સર 15 દિવસ તો એટલા સરસ જાય છે ને અને ફરી પાછી ખાંસી ચાલુ થઈ જાય. બાકીના 15 દિવસ તો અમારા માટે બહુ જ સરસ હોય છે. અને આખી સિઝન જેવું દિવાળી આવે અને શિયાળો ચાલુ થાય ત્યાં સુધીમાં તો એટલી બધી ખાંસી આવે છે. So this is an intermittent coughing This is most likely an asthma or an atopic changes. Any child having a recurrent cough with poor growth. કે સર ખાંસી તો આવે જ છે, વચ્ચે થોડું સારું પણ થાય છે, but child doesn't look good. And if you look at the growth chart, he's faltering into the growth chart. His weight, height percentile are gradually going down. His appetite is going down. Probably this has something more to go into the lung parenchyma, maybe COX, or maybe something wrong. So if you maintain a good growth chart and a child having a recurrent cough and not doing well, if there is other system involvement also, probably some more insight is needed in these cases. Any child having a persistent cough, કે સર 1.5 મહિનો થઈ ગયો, ખાંસી મટતી જ નથી, low grade fever is there, poor growth is there, family history of a disease is present, probably this is a chronic lung pathology. Most likely in our setup, it is a COX disease which comes with persistent cough, low fever, poor growth. However, tuberculosis is also changing its scenario, and anytime it can behave like a trump, or sometimes it can be a very silent disease to proceed. Look at some other cases. Noor and Nisha, they are 9-month female twins. Same history of fever, cough, cold. They were sick looking. There was a mild congestion in eyes. I'll show you the photograph. Flushed body was there. And it was almost the same period like what we are getting at present. Maybe in your practice also you have seen these cases once I show you a photograph in the month of February and March. Child Noor has a large pneumonia. Look at the X-ray, right upper zone pneumonia is there. So we just thought that such a small child, large lobar consolidation, likely to be bacterial. We started with antibiotic. Most common choice would be amoxicillin, but child was not responding on 3rd, 4th day also. We thought of giving a vancomycin to step up the antibiotic. But next day morning in the round, we could see that child had both red eyes. This was her twin sister. She also got same problem. Look at the photograph of both twin sister. One is a patient who had a vein flow. The second child was also admitted on 2nd day. Both of them had a red eye, lobar consolidation, coughing. This is most likely a viral etiology, and in viral, this presentation as a lobar pneumonia is usually in adenovirus. So adenovirus can come as a patchy consolidation and make us full. If you have no lobar consolidation, both red eye, severe coughing at present in Surat and in Gujarat also, measles epidemic is going. Every day we see one case of measles who comes with a high fever, red eye, Koplik spot and a rash. So adenovirus, measles, both mimics. Adenovirus causes large consolidation, and if you all can remember, I think last November or maybe 24th November, December, we had a huge epidemic of adenovirus where patient needed ventilatory support also. This has been proved by a respiratory biofire testings. Now let us go to the flu-like disease. What are the clinical symptomatology? How can we be rational for influenza-like disease? And what should be the treatment modalities? Just look at that. The common question comes into our mind કે ભાઈ આપણે ત્યાં તો ફ્લૂની બીમારી છે જ નહીં, સર રસીની શું જરૂર છે? ફ્લૂ થાય છે આપણે ત્યાં? Yes, it does happen. The incidents are increasing. In India, the peak is between February, March, and the second peak comes into the August, September. Maybe northern, southern, central zone have some variability, but we do have a 2 peak of the influenza season. Look at the cases of influenza infection. Almost it has reached to 28,000 in 2019, and the mortality was 1218 in 2019. These are reported data from Indian government. And as we all know, we all underreport the cases. So the number of cases are significantly high. The Indian data, these are taken from our Purple Book of Indian Academy of Pediatrics. 5 to 10% of all ARI due to influenza. 10 out of 100 child per year suffer from influenza, and almost 178 to 180 per 1000 children per year below 1 to 2 years, they are suffering from flu disease. The influenza associated respiratory infections are 33 to 44 per 1000 children per year. And in 2009 pandemic, where we had a very bad disease, 22.8% were positive for influenza. And in 2015 up to March, more than 30,000 cases were reported of influenza and 1809 deaths were reported. Now, let us look at the microbiology. Influenza viruses, there are three types, A, B, and C. A causes frequent epidemic due to minor antigenic variation and periodic pandemics due to major antigenic variation. Influenza B virus, it infects only humans, cause local epidemics. And influenza C virus, it infects human and swine. Influenza type C infection generally causes a mild respiratory illness and are not thought to cause epidemics. Nowadays, majority are H1N1, H3N2, and every year there is a variation in the type of the influenza virus. In influenza, when we often discuss what is drift and shift. Influenza virus has a various antigenic characteristic. When you have H and N, these are the two major antigens, hemagglutinin and neuraminidase. When there is a major shift in one of the antigen, we call it as a drift. And when there is a minor variability, we call it as a shift. So major antigenic variation, when it comes, it causes a huge pandemic. Minor antigenic variation or a shift in minor antigen, it may not cause pandemic, but epidemic does come. Flu virus is transmitted with person-to-person contact. Almost a 6 feet distance is to be maintained. Otherwise, the virus can spread. It mainly spread by droplet, which is made with when people cough, sneeze, or talk. These droplets can land in the mouth or noses of people who are nearby or possibly be inhaled into the lungs. People should stay away from the affected person and stay home if they are sick. It also is important to wash hands. Hand wash we should maintain. Most healthy adults may be able to infect other people beginning 1 day prior to onset of the symptoms and 5 to 7 days after becoming sick. And children may pass the virus longer than 7 days. Now, when you get the patient in the OPD, we are little bit clinically deciding what is happening. So we have a ILI or influenza-like illness, H1N1, severe acute respiratory tract infection called as a SARI, and COVID-19. Practically speaking, it is difficult to differentiate whether it is a COVID virus or severe acute respiratory due to some other virus or H1N1. But theoretically, if you have a more breathlessness, it is more likely H1N1 or a swine flu. Then, along with breathlessness, COVID can also come with these. Severe acute respiratory due to other virus may have a breathlessness. If you have a loss of smell, loss of taste, probably COVID, we all know. Diarrhea, more pronounced in COVID, but H1N1 and SARI can also have diarrhea. So clinically difficult to differentiate, but a few minor points would give us a hint, like loss of smell and loss of taste would favor more of a COVID. However, the management protocol remains almost same. Now, if you get a case, how could you diagnose there? It is a respiratory viral disease due to some virus. Nowadays, we have a few well-advanced tests available. Previously, on academic ground, viral culture was done, which is not in a use for a private practitioner, but a DNA or a sequencing testing are very much easily available, where we take a throat swab and we send it for a genetic RNA DNA isolation. We have a flu panel also, flu with COVID, with RSV virus. The 6 virus panel is also available. And that is a gold standard. It has a very good correlation, specificity and sensitivity is also high. And now it is available in majority of the laboratory. So we can go for these antibody titer like influenza IgM antibody is not very much validated test because IgM level increases after 7 to 10 days, not immediate. So for us, throat swab and a flu panel, which is very important test. What are the common complications of flu? Majority of the patients has a very mild disease, but any child who comes with a respiratory compromise, who has some CNS sign symptoms like drowsy, irritable, not feeding well, breathing very fast, getting cyanosis, and getting other system involvement also. These are very worrisome point or complications of flu. Primarily, it is respiratory compromise, maybe getting pneumonia, maybe getting respiratory exchange of oxygenation is affected. So these are the signs of hypoxia. And few patients may have other system involvement also like cardiac, liver, and CNS. Same way in the adults, if patient is hypoxic, patient would have breathing difficulties, little bit confused, dizziness, severe persistent vomiting. These all are complicated signs of flu disease. Normally, when you take the X-ray, this is an X-ray of one patient which was taken in 24. X-ray shows a bilateral reticular pattern or classically called as an interstitial involvement. You may not get a lobar pneumonia like in Streptococcus pneumoniae or sometimes in adenovirus disease. But here, the reporting would be prominent bronchovascular markings, mild bronchitis. That would be the reporting in the X-ray. But the interstitial involvement here is a very significant, and if clinically patient is not better, this is going to worsen the situation. So this is called as an atypical pneumonia or interstitial pneumonia due to viral pathology. These virus could be flu disease or could be other virus also. So when you suspect this, should we start with antiviral therapy? Let us look at the situation. If it is a very mild disease, we categorize it as a category A. Category A is a mild symptomatology. You just need a bed rest, increased fluid consumption, cough suppressant, antipyretic, and NSAIDs. Most patients would recover within 3 to 4 days, and weakness or a malaise, patient would tell કે સાહેબ બહુ થાક લાગે છે, બહુ weakness લાગે છે, which may persist for 2 to 3 weeks. Category B is a little bit more symptomatology where patient would have a high fever, cough, cold, vomiting, little bit breathing difficulty. This is category B. And category C is more worsened where you get hypoxia, high fever, drowsiness, and a family involvement. Then this is category C. So when you get a category B or C, you should use the antiviral drug oseltamivir. What is oseltamivir? To fight against the flu virus, we have a two group of drugs. One is a neuraminidase inhibitor, and the second is adamantanase or M2 ion channel blocker. Neuraminidase inhibitor, they block the viral neuraminidase enzyme, which is critical in releasing viron from the infected host cells. These drugs are active against influenza A and B, and the prototype drug is oseltamivir. Zenamivir is not available. Other side, adamantanase, they interfere with hydrogen ion channel activity of the influenza A virus, thus blocking its entry into the host cells. It is active only against influenza A virus, not against B. So these drugs like amantadine, remanatidine has an inferior choice than oseltamivir. Oseltamivir is active against A and B, both the viruses. So oseltamivir, it is a potent and selective inhibitor of the neuraminidase enzyme of the influenza virus A and B. It is a prodrug which is converted into the active form in the liver. It inhibits influenza virus replication and its pathogenicity. It prevents further spread of infection. It is effective against all strains of A and B virus, including the H5N1, swine origin H1N1, and H9N2 strain also. This is the photograph. How does it work? Just look at that. This is Viron. You have a neuraminidase enzyme. From here, there is a release of new Viron and viral replication goes on. So neuraminidase, hemagglutinin, these are the two protein molecular antigens which is present on viral. When you give the oseltamivir, if started earlier, it will block these enzymes and there is a blockage of the new viral release. So viral copy or the viral number significantly reduces when you give the oseltamivir. So it was the first oral neuraminidase inhibitor. It is approved in more than 100 countries. We have an FDA, CDC, American Academy of Pediatrics approval for using oseltamivir. What should be the dosage? It is available in the capsule form and the syrup. Capsule is 75 milligram and syrup is 12 milligram per 1 ml. So the below 15 kg, the dose recommendation is 60 milligram per day, or in syrup, it is 2.5 ml BD. This is the table mentioning the various doses. More than 40 kg, you have to give 6.25 ml BD. Now, there is a concept of chemoprophylaxis, which is shown in the third column. When you have an exposure to the influenza disease, the chemoprophylaxis for 10 days can be given with these dosage regime. Infant below 2 weeks may not receive the prophylaxis, but therapeutically, when you get the disease, it can be given in the dose of 3 milligram per kg twice a day. This table is very well available on the internet also. So when do you suspect influenza? Like fever with mild ARI? This could be any viral, maybe influenza. Fever with cough, cold, diarrhea, maybe influenza. Both the patients are healthy, doing well. They don't need oseltamivir. Any child, fever with respiratory sign symptoms and immunocompromised host. In pediatric, the common immunocompromised hosts are nephrotic syndrome, sickle cell disease, maybe on chemotherapy, maybe having a cardiac disease, maybe having a GIT congenital disease, maybe having a metabolic disease. So here also, if it is a category B, we need to start the oseltamivir. Any child coming to you with fever and severe respiratory distress, more favoring with respiratory pathology like normal CBC, CRP, SGPT is normal, but child has a very severe respiratory distress. You consider these as a flu disease. If possible, go for a respiratory panel. If not affordable, then also authorities WHO recommend that you should start oseltamivir empirically in any child having a severe respiratory distress. You may hunt etiology afterwards, but early starting of oseltamivir does help in faster recovery. Any child having fever with patchy consolidation in immunocompromised host coming to you in the season of flu. See, these are the three background: large pneumonia, fever, and immunocompromised host. Empirically giving influenza medicine, oseltamivir is also justified. So guideline recommendation, WHO do recommend that empirical treatment is strongly recommended. Treatment should be started as soon as possible. However, if you start late on third, fourth day also, then also the chances of complication, morbidity are significantly less. Recovery is better and faster. Laboratory confirmation of influenza is not necessary for the initiation of treatment. Negative lab test does not exclude the diagnosis in all patients. Therefore, early start is recommended. And as we mentioned that high risk individual have been exposed to a patient with influenza, consider presumptive treatment with oseltamivir. And early empirical supportive therapy and monitoring is important. Give empirical antimicrobials to treat all likely pathogens causing SARI. This has been recommended by Ministry of Health and Family Welfare. So any child having a respiratory distress, empirical antimicrobial with oseltamivir is justified. Empirical antibiotic treatment should be based on the clinical diagnosis, community acquired picture, healthcare associated pneumonia, if infection was acquired in healthcare setting, or sepsis. Empirical therapy with neuraminidase inhibitor for the treatment of influenza when there is a local circulation or other risk factors, including travel history or exposure to animal influenza virus, we should start with oseltamivir in these patients also. So this is what a standard recommendation. And there was a one study in adult where you had a community acquired pneumonia who test positive for influenza. Should the treatment regime include antiviral therapy? Any community acquired pneumonia with an epidemiology favoring influenza disease, we should start oseltamivir empirically. In this study also, it was found that the patient who had a community acquired pneumonia did receive influenza treatment, did not receive influenza. Those who have received influenza treatment with oseltamivir plus antibiotic, they recovered bit faster than this group. So empirical treatment may be justified, or community acquired pneumonia with associated positivity for influenza, they should be given oseltamivir. So in summary, proper diagnosis clinically, laboratory wise would help and treat the patient early, which will prevent the flu complications. Empirical use of oseltamivir reduces lower respiratory tract complications, hospitalization, and antibiotic use. It has been recommended by WHO, American Thoracic Society, Ministry of Health and Family Welfare of India, and so many other agencies. They do recommend that oseltamivir should be used because it is one of the safest drug. A very minor side effect like diarrhea and occasional vomiting because of the test of or palatability of the drug for pediatric patient. Otherwise, it's purely hepatosafe, cardiosafe, and neurosafe. So oseltamivir, it has its role in management of influenza-like symptomatology in a clinical given scenario of category B and category C. I think I stop here. Thank you so much to my august audience and to the hetero healthcare also. If you have any question, we can discuss out. Over to you, Prashant sir.
Thank you so much, sir. I'll come to some of the panel questions.
Yes, sir.
You can see the slide, sir?
Yes.
So you feel the the viral infections have increased over a period of time as compared to yesteryears?
Yes, sir. The viral infection has a specific seasonal variability. Like at present in February, March, every year we get the disease because the season is changing. Second thing, in the monsoon season also, which is highly favorable for viral infections. So definitely incidents are there throughout the year. Some plus minus could be there.
Okay.
Over to you, sir.
Generally, sir, how soon a child is brought to pediatrician? पहले तो GP के पास जाते होंगे.
See, even they can go to the
Yeah.
general practitioner, sir.
Correct.
Absolutely fine.
Correct.
Only thing, any doctor like me as a pediatrician should be able to know that what are my limitation in diagnosis.
Absolutely
If
correct.
I get any patient who is getting convulsion, I manage them primarily, then admit and refer to the neurologist.
Correct.
Same way, if a family physician sees the patient and look at the vital parameters. Temperature, if it is very high, coughing very badly, his pulse ox is showing low oxygen, probably he should not indulge into this case. He should refer to the concerned pediatrician. Second thing, if a family physician has seen this patient cough, cold on day one, he should make a note कि काले तकलीफ વધારે લાગે તો પાછા આવજો, because SARI and respiratory distress in viral comes on second, third or fourth day only. તો તમને સારું ન લાગે તો બેન કાલે પરમ દિવસ પાછા આવજો. And second, third day, if child is in respiratory distress, little bit confused, probably he should refer to the pediatrician.
Pediatrician. That's wonderful, sir. Should oseltamivir be started empirically or after investigation? You should wait for investigation report.
No, sir. It should be empirical only.
Exactly. You have told this.
Investigations is more costly.
Correct.
What I mentioned is a flu panel in Surat or like Newburgh, which is there in Newburgh, Metropolis. You name the big labs. They charge around 4,000 to 5,000.
Oh my God.
Flu panel. And that also the technique of collecting the swab is important.
That is,
collect it from oral cavity, you get
not
it. And the medicine cost hardly 400 to 500 rupees.
Correct.
So it is better to start empirically. And we are doing rational approach. We are not doing irrational using oseltamivir.
Secondly, if you treat, the cost of admission and other complications is further high, sir.
Yes, sir. Agree. But at least in category A, where you have a very mild
where you may not require anything.
But category B with high risk patient, you should start. And category C, obviously.
Sir, category A can anytime go into category B, no? And C.
100%. So what I told you, sir, a doctor should tell કે બેન જો આ શરદી ખાંસી વાયરસ જ છે, after 2 or 3 days તમને એવું લાગે કે ખાંસી બહુ વધી ગઈ છે, બાળક ઢીલું લાગે તો આવજો. આ વાયરસ છે એટલે અત્યારે એન્ટીબાયોટિકની જરૂર નથી. પણ આપણે નજર રાખવી પડે. This is what I tell the patient.
Correct. What are the factors on which clinical response? एक तो starting early.
Yes.
And secondly?
First thing is starting early. Second thing, proper dose adjustment according to the body weight.
Correct.
Third thing, they should shake it properly and give them in a good way. And the fourth, child should not vomit it out.
Yes.
If he vomits out, then repeat the dose. If he vomits out within 30-40 minutes, then also you should repeat the dose. Overdosing is not going to harm them.
Can you give it on empty stomach?
Fine, sir. I think. No problem.
De do bas. That is important.
Pediatric patient may gastritis and everything is very rare to sir.
Generally, how long? Of course, your
5 days. 5 days. 5 days therapy is there.
Treatment is. And can antibiotics be prescribed? Because we have got a habit of writing antibiotics that first reflex hota hai.
Normally no, sir. If you have a classical red eye, running nose, coughing, diarrhea, this is viral. So we avoid writing down antibiotic to them. We usually start oseltamivir in them.
लेकिन किसी को अगर लगता है कि एंटीबायोटिक देने के बाद में कॉन्फिडेंस आएगा तो you can very well prescribe.
No, not on at least first, second days, but fourth, fifth day you decide. You take a call.
Yes. How is it tolerated? Any major side effects?
Very well tolerated. No major side effects, sir. It's very safe medicine.
No contraindication, precaution. Oh, that's what we GPs feel, no? Yes.
Obviously, sir, no obvious contraindication. A very textbook written complication, idiosyncratic reaction, or past history of drug-induced rash.
That can happen with anyone.
Any drug, even paracetamol is the most toxic drug, sir.
So, your overall experience with oseltamivir, to take home message for the audience.
Sir, I have been using it, but I select the season like February, March, August, September. I'm using it empirically in category B and category C. Obviously, category B in the OPD, we do start empirical oseltamivir for infancy, for 1.5 to 2 years, who is underweight, who has a cardiac problem or other disease. We do start, and the experience is excellent. Hospitalization rate reduces significantly.
Right, sir. Thank you so much for sharing your experience. I'm sure the doctors who have attended have benefited out of your experience. क्या होता है अपने डॉक्टर से experience is more important than textbook reading, and I'm sure they have benefited. Thank you so much. Thanks
Thank
all
you.
the doctors who took time. Thanks Sanjana. Thanks Payal. Payal, you want to add anything?
No, sir, absolutely nothing. I really thoroughly enjoyed doctor's presentation. It
Yes.
was so clean and so to the point that I'm sure the doctors who have attended this
Yes.
session might have got
Very
take-home
correct. Very
points as
correct.
well.
Very correct. Thanks so much, sir. See you soon.
Thank you, sir.
Thank you so much,
sir.
sir. Bye-bye.
See you
Thank you,
soon, sir.
Payal. We had
Thank
been
you.
talking for
Yes.
many days on phone. I could see your face today.
Yes, that's the entire purpose that I could come on the video call so that there is a connection as to whom you're talking, the face that you're talking.
I have saved your name with two to three times I changed. First was Pahi, then Rishi, then now it is a Payal. Okay, okay.
Okay,
Okay, sir.
chalo.
Thank
Bye-bye,
you.
doctor. Have a
Okay,
great
good
day.
Bye.
Bye-bye.
afternoon. Yeah.
Thank you,
Thank
sir.
you, Dr.
Good day.
Prashant.
Yes, yes. Good day.
Bye, Sanjana. Bye.
Bye.
Bye, Sanjana. Thank you so much. We are leaving. Thanks, Payal. Good, no? It was very good.
It was indeed very nice.